Hello, everybody, and good evening to our next Twitter space in the series that we've been doing for about a year and a half. Talking about medication and medication management for people living with dementia, which is a very important topic because obviously we know dementia is a progressive condition, that there's no cure for it, but actually there is medications that can help to relieve some of the symptoms. So I'm really delighted that I've got an excellent panel for you this evening, who I'll invite up shortly to give us a bit of an introduction to themselves, and then we'll go on with the conversation. Just to let you know some of the features in case you're not entirely sure of how it works, what Twitter Spaces is, why you're here, what's going on. Just to let you know that you will see a little heart with a plus sign down at the bottom of your screen. If you've been here before, you'll be familiar with that, but it's just a really good way for you to let us know that you're here, that you're listening. So feel free to hit those emojis so that we know that you're here, that you can hear us, and that you're engaging. Obviously, if you're listening to this again on YouTube, that you won't be able to listen. You won't be able to do that. You won't join in this way. And if you're listening to this again, as it stays live on Twitter for a month afterwards, obviously you won't be able to do that either. But please do hit those emojis, and I can see some of you doing that now. So thank you very much. It's really reassuring for us, the speakers, to know that you're there and that you're hearing what we're saying. So thank you so much for doing that. The other thing to let you know is that there is a feature on Twitter where you can turn captions on and you can read what we're talking about. And I know that for some people, that's a really useful feature to be able to read what we're talking about. So if you do want to turn captions on, the way to do that is towards the top of the space, you'll see three little dots. If you hit those three little dots, it will give you an option to turn captions on and actually read what we're talking about that way, because as I say, I know that's a useful feature. Again, if you're listening to this outside of the live session, you won't be able to do that, but it is a useful feature for many people to be able to follow the space that way. Other things to tell you: about halfway through this session this evening, I'm going to turn on the ability for people to come and join us to ask questions. Won't do that yet because I want to give my guests a chance this evening to talk and to share their knowledge with you. But once I do make the mics live, you'll be able to come up and request the mic and ask us a question, and we will do our best to answer it for you. The other thing that you might want to do is type us in a question. So you'll see towards the bottom of your screen a little speech emoji. And if you click on that, you'll be able to ask us a question. And for some people, I know again that that's a preferred method of communication, because actually joining and using your voice to communicate might seem a little bit of a barrier, but you might be quite happy to type a message in that way. So that's another way that you can get in touch with us this evening if you want to ask a question. I think that's probably enough from me. I'm going to invite my speakers up to say a little bit about who they are, and I'm going to ask you, Hannah, to come up first, because that's the order that you are on my screen. So Hannah, can you unmute yourself and say hello to everybody?
Hi, can you hear me?
We can hear you beautifully, Hannah. Thank you very
Okay,
much.
awesome. Okay, great. So I'm Hannah Hussain. I'm currently a PhD candidate and I'm studying a PhD in quality of life outcomes in people with dementia. And so that's kind of what I'm doing at the moment. But I'm also a community pharmacist. So I practice as a community pharmacist in your local community pharmacy. So I'm kind of aware of medical prescribing and things like that for treatments for people with dementia. So that's me.
Perfect. Thank you so much, Hannah. And Stuart, can I ask you to? Stuart's hiding behind a Superman logo or picture. So can you unmute Stuart and say hello to us this evening?
I certainly can. Same question. Can everybody hear me?
We can hear you loud and clear, Stuart.
Excellent.
Thank you.
Before we start, I will explain the Superman logo. It's not to imply that I have any superpowers, but actually, if anyone knows the history behind Superman, the S from his family indicated hope. So I think it's quite an interesting emblem for someone who works in the field that I do. Anyway.
I love that. I did not know that. There you
Yeah,
go.
yeah.
We're already sharing the knowledge in this,
So anyway,
this
so
evening.
yes, I'm Stuart. I'm an Admiral nurse. I've been an Admiral nurse for just 2 years, a little over 2 years. I work in an area of Leicestershire called Charnwood. Um, I managed a memory service before that, and I've probably got around 35 years experience working in dementia care, and I'm also a non-medical prescriber for about 19, nearly 20 years now. So yes, I'm happy to be here.
Fantastic. Thank you so much, Stuart. So we've got a real wealth of knowledge on the stage already. And my job tonight, I am an Admiral nurse, so I will potentially answer some of the questions, being an Admiral nurse for about 20 years. But I'm here this evening to host the conversation, to look after you, to share this, while we share this knowledge with people who are listening this evening. So I'm going to be asking a series of questions, and I'd like to start, Hannah, if I may, with you, please, this evening, in
Sure.
terms of just setting the scene for us a little bit. Can you tell me a little bit about the numbers of people in the UK with dementia, and actually, if you do have any stats around the numbers of people who take medication on a daily basis, if you know that.
Yeah, currently there are nearly 1 million people living with dementia in the UK alone. So it's a large proportion of our population, of which over 40,000 are living with young onset dementia. So it just gives an idea of kind of the distribution of the ages of onset. And the total numbers are estimated to increase to over 1 million by 2030, and then nearing 2 million by 2050. So the proportions are growing. And in terms of the numbers of people that are taking dementia medications daily, it's hard to know just exactly the proportion, but in terms of the number of units of dementia treatments prescribed, it's risen by nearly 2 million, so nearly twice the amount from 2011 to 2016, so that's just in 5 years alone. So it just gives us an idea of the fact that more and more people are taking dementia medications, prescribed dementia medications daily in the UK. And just to kind of sum up, the total cost of dementia drugs in England alone is around 28 million to the NHS. So, there's a large proportion taking dementia meds, and that number is indeed growing.
Thanks, Hannah. And I guess the other thing, of course, is that I know you quite rightfully reminded us that there's 42,000 people who will be having, have young onset dementia, but actually, a lot of people living with dementia may well be taking other medication as well. And, it's not just the medications that they're taking to help with the dementia. And do we potentially, I mean, I don't know if you do have any stats around that. Do you have any kind of idea about the number of medications might is there any stats around that?
It's not something that I kind of know on the top of my head in terms of the numbers of medications that a person with dementia might be taking. It really depends case by case and person by person. And it also kind of depends on the age of onset as well, and the type of dementia that the person has, and also any of their pre existing conditions. So a person might be taking multiple medications to help with the dementia specifically, but also maybe taking other medications for other conditions, like you said.
So it's potentially a lot of people then are going to be taking a number of tablets over the course of the day, and different types of medication, and I guess that's why we know this is an important topic. We know this is a topic that we get asked lots of questions about, because the numbers of people who are going to be taking medication is going to be quite large, isn't it, potentially? So in terms of the sort of,
it's kind
I'm
of
sorry, go on.
different things that people living with dementia might be taking medications for. Like we said, there's different comorbidities, but even in terms of managing their dementia itself, oh sorry, can you hear me?
Yes, we can hear you. Sorry,
Oh,
yes,
sorry,
yes.
it was reconnecting. Sorry. Yeah, there's kind of two main drug categories in terms of dementia management drugs. So there's the cholinesterase inhibitors and the NMDA receptor antagonists, but I'm sure we'll talk about these a little bit more later. But beyond that, there's other medications that can be integrated into a person's dementia care plan just for managing their dementia. So things like antidepressants as well, which may be indicated for certain types of dementia more so, like frontotemporal dementia. But also, if a person presents with vascular dementia, for example, they may need things like medications to manage their blood pressure, like beta blockers. People may know atenolol as a more common beta blocker to control that type of dementia. And also things that help with diabetes management, like drugs like metformin, also indicated in vascular dementia, but also treatments that may be used for smoking cessation. So, even though a person may be taking multiple drugs for multiple conditions, there's also multiple drugs that can be taken for different types of dementia, which I guess just adds another layer of complexity to it all.
I think you're right. I think the complexity is really out there, isn't it? And I know that often, people ask questions about why somebody might be prescribed a medication and why somebody else might not. And you've talked a bit about vascular dementia and some of the different drugs that might be available or used. And can you? I mean, what's your take on that? What sort of information can you share about why different people are offered and receive different drugs?
Yeah, so it really depends on a range of factors. So, like we said, the type of dementia that a person is diagnosed with, but also how progressed their dementia might be when they're presenting to their clinician. So, the drugs tend to be most effective in a person that's got kind of early stage dementia. So, we'd say mild to moderate. But also, if they've got pre-existing conditions that could result in drug interactions or the drugs could worsen those other conditions, it may be decided that medication's not the most suitable option for managing their condition. And it should be noted also that medications don't necessarily work for everyone. So a decision on whether or not a person should be taking medications is really between the person and their prescriber, which will usually be their GP.
Perfect. Can I ask you a follow-on question from that? Because you mentioned about work for people, and they're not going to necessarily work for everybody. And I know that it's quite complicated to explain how these drugs do work. But can you tell us, the simplest way as possible, I guess, a
Yeah.
little bit about how the drugs actually do work?
Yeah, so there's like we said just before, there's kind of two main drug classes. So these are the cholinesterase inhibitors and the NMDA receptor antagonists. So they've got very fancy scientific names, but their mechanisms of action are related to the pathophysiology of dementia, which is it's quite complex and not really that well understood, but scientists have been working hard to develop theories on what causes dementia, which has resulted in these two kind of main drug classes. So, one of the theories is that dementia is caused via a loss of the central cholinergic neurons, which results in a deficiency in acetylcholine, which is a a key neurotransmitter that's involved in memory and learning. So obviously, when that's deficient, it's impacting that person's ability to learn new things, and it's impacting their memory. So that's why a person might take an acetylcholinesterase inhibitor. It prevents the reuptake of this neurotransmitter, which will lead to an increase in its duration and its action in the brain. And then you've got the other drug class, which was the NMDA receptor antagonists. So these block these receptors within the brain. They act at a cellular level in the brain to limit calcium influx, which is thought to reduce brain cell death. So it's this influx of calcium that is thought to be associated with the death of brain cells, which again is thought to be a cause of dementia. So they're the kind of two main drug classes that are used, and that's kind of how they work, and it's based on these theories.
Thank you, Hannah. That was really fascinating. Actually, it's always lovely to hear somebody who's so knowledgeable talking, because you just learn. You feel yourself learning. So can I ask you? So one of the things that we talk about when we talk about these medications, actually, well, any type of medication in these categories, we're talking about how they actually work, and we know that that we it may help to slow down the decline, someone's cognitive decline. But can you tell us a little bit more about how what the key benefits are to taking these medications?
Yeah, so like you said, the main thing is kind of slowing down that decline in cognition, um but there are other things that these drugs can aid with. So they might help with anxiety, concentration, improve the person's memory. As a result, they can improve and boost motivation and daily life for the person with dementia. But it should be highlighted, like you said at the start of this transmission, that these drugs are not cures. They're used to relieve symptoms of dementia. So even though there are a lot of benefits, they're not there to kind of get rid of the dementia.
Yeah, and I think that's the vital thing, because over my career, and I'm sure Stuart, you would agree to this, that you often hear people talking about these tablets as if they're going to cure or stop or halt, and actually that's not really how they work, and I think that's an important thing for people to know. Can I ask you, Hannah, about actually a little bit about polypharmacy, because I know you haven't particularly mentioned it, but it's something that comes up quite a lot. If we go back to what we were talking about earlier, about the numbers of multiple medications that somebody might be taking, and again, it's just a term that I think it might be useful for our listeners a little bit more about.
Yeah, sure. So polypharmacy is basically when a person is using multiple medications to manage their health conditions, and these conditions are usually chronic. So it can be defined as taking five or more different medications in one day, but that's not like a technical definition. And a person may be a polypharmacy patient. They may need multiple medications to treat their ailments, and it's important to bear in mind that there could be potential drug interactions, or that being a polypharmacy patient could render drugs as less effective, or sometimes unsafe. But these factors are going to be carefully considered with a prescriber. And when a person receives a prescription, they've been prescribed, but they're also checked by their pharmacist to ensure that it's safe. So it's not something that people need to worry about, but it's just something to bear in mind.
Perfect. Thank you so much, Hannah. And I was just thinking while we were talking as well about interventions for all sorts of reasons. They might not be able to tolerate them, they might not work, or they might not be indicative as being useful. But what about alternative therapies, that, you know, non-pharmacological therapies that people might be able to explore? And this might seem like an odd question to ask a pharmacist, but I do know, because we've spoken before, that this is an area that you're very interested in. So could I ask you to share a little
Yeah.
bit?
Yeah, so yeah, it is a personal interest of mine on pharmacological interventions, because of the nature of my PhD, which is in measuring quality of life in dementia, and it's just a different way of being able to measure the effectiveness of an intervention. So traditionally, drug therapies are measured by measures of cognition, which, if you're measuring a non-pharmacological intervention, may be shown to be ineffective if measured by cognition. But if you're looking at a person's quality of life, it might be that these alternative therapies are actually more effective. So that's why they're kind of one of my areas of interest. But these kind of things can include things like exercise interventions and nutritional advice, but there's also more targeted therapies for people living with dementia, things like reminiscence therapy, which involves discussing events and experiences from the past. There's treatments that use music and dance. There's also ones that use technology like virtual reality. And there's also tools like cognitive stimulation therapy, and that's not the same as cognitive behavioral therapy. This include like cognitive stimulation therapy includes things like puzzles and crosswords, things like discussions, meetings, and social activities, and they're there to kind of challenge the brain and keep the brain active. And I think that one of the key benefits of these types of interventions is that there are also really great social opportunities for people living with dementia, which can address some of the wider issues that possibly drug interventions can't. Things like loneliness and isolation, which kind of crop up a little bit with this population too. So yeah, big advocate for them.
Yeah, perfect. And I think we all are probably on
Yeah.
this space, because it's more than just taking tablets, isn't it? It's actually, how do you manage your life, and what other things can help, you know, in terms of your quality outcomes for you. Thank you so much, Hannah. I'm going to come back to you in a little bit, so don't disappear, please.
Sure.
But I'm just really keen to bring you in, Stuart, if I can at this point. Are you still with us, Stuart?
I'm still here.
You're still there, Phew. That's always a relief. So I know that I can see a question that's popped in, so I will come to that in a minute. And I obviously do want to get us to a point where we open up our phone lines if people want to ask questions of us. But can I ask you, Stuart, in your experience as a nurse and you know, somebody who's been working for such a long time as you have in this area, what kind of questions do you know? What kind of common questions do people ask you when they, you know, around medication? What's one that you would say you've heard a few times?
So I think in responding to that, I'm going to sort of think back beyond my current work, really, because having sort of worked in different parts of dementia care, I mean, some questions will have come up at different stages, and particularly when in a memory service. And I suppose those lots of those will either relate to the treatments that we've talked about already for dementia, or sometimes perhaps treatments such as antidepressants or even antipsychotics. And I mean, there are an awful lot of questions that people have, particularly when they're getting a diagnosis. But one of the I suppose one of the themes that's occurred that I can sort of recall really is that decision around somebody actually starting treatment for dementia, the 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 explanation that's given that what this medication will do, and people sort of wondering whether there would be actually any value in taking that, whether it would be suitable for them, whether it would be safe, whether that's the right thing to do, and that can be quite a difficult decision, particularly for the patient to weigh up. And there's no quick and easy answer to whether or not you should start that treatment. I mean, these are medications which have been around for an awful long time now, and in as much as that means we know their safety profile, it also means that we don't have amazing research for treatments to follow on at this stage. So these are established, but they're all we have. And as Hannah's obviously indicated, they're not curative, but they do, it's important that they extend the quality of life for an awful lot of people in terms of maintaining a level which they're at for some time to come. I think that decision as whether to start the treatment can depend on the stage of illness and to some extent the sort of social circumstances, the person's currently, whether they're living alone or whether they're living with someone, whether in a care environment. I think it's important that if a person is being asked about starting these, that it's an informed choice. And it's important that we remember consent, capacity and consent, and that we explain the benefits and the risks that medications entail. And we do that in a way that's accessible and that's not full of jargon, but by the same token, not omitting what's necessary to know. Any decision we make, we should be trying to determine as best we can whether weighing that up or whether that's what we want. So I'm very keen that any decisions around medication involve an assessment of the person's understanding of that and whether they see the benefits balanced against the disadvantages. I think in terms of starting that treatment, we've got to look at whether it's actually safe to start. You may delay that decision because of difficulties around somebody needing prompting, needing adherence aids, perhaps needing a package of care, arranging. And obviously, if there was a risk of somebody perhaps taking too many and overdosing, then you would delay any decision or want to recommend delaying that decision until there were sort of safe structures in place. Um, and I think in any medication decision, there are always going to be side effects and risks. There is nothing in the BNF, in our Bible of medications that doesn't come without some risk and some side effect. So we must be open and honest as to what those potential side effects are, and help the person to make that decision.
Thank you. And one of the other things that I was just thinking while you were talking there is that we often hear, certainly in my experience, people asking questions about if I start this, how long I'm going to have to take this, or even as a medical team, we did make a decision that is this actually effective any longer? Should somebody remain on it? And what's your experience around that that sort of question?
Do you know, Vic, that's a really interesting and not entirely unusual question, because any medication, particularly what we might consider a psychiatric medication, the obvious question would be, how long do I need this for? And you might be forgiven for thinking of this in terms of an antidepressant or an antipsychotic or a conventional psychiatric treatment that you would take usually for a defined period of time. But that question, I mean, has arisen an awful lot. And the pragmatic answer to that is actually the evidence for benefit long term for these medications is really hard to measure. There was one single trial done, I think 10 years ago now, which had, I think, less than 300 people, if I remember. And that trial demonstrated that when the medications are stopped, there were further changes to a person, particularly in their abilities to continue with areas of self-care. Now, that was a small trial, and ethically, you wouldn't really justify further trials of stopping these medications. So that's the only evidence that exists. But on that basis, on the basis of what that trial showed, the advice tends to be you carry on taking this medication to help with the dementia, because we believe there's a benefit, even when it's at the stage that it's hard to measure what that benefit is. And I know from my own clinical experience in the past that when it has been stopped and believed to be having no benefit, further changes, further loss of self-care skills can follow on, and those don't always return when the medication is restarted. So it's a hard one to answer with any confidence, but as I said, the only evidence base that sits behind that is that the current evidence would indicate that there is a benefit to taking these for as long as you possibly can tolerate them. Now, having said that, there may be later stages in someone's journey through dementia when it's just not appropriate anymore. If there is if someone is at a more palliative stage in their care, then concerns around medication to slow down their dementia may not be uppermost in their and their family's minds. So that would be an appropriate time to consider whether the medication should continue or not. I think we have to consider quality of life as well. We have to sort of remember that if someone is perhaps at a late stage in a care home, and they've maybe suffered loss of appetite, which can be a side effect of Donepezil after a number of years, stopping that medication might improve their dietary intake, and that's probably more important than a small amount of benefit that they're getting from the medication. So it's not an easy one to give a generic answer to, but I think each situation would be assessed on merit. For most people, they would be taken for a long time, and decisions around ongoing care towards the later stages are also important. I think I would probably add one other thing as well, sort of whilst it crosses my mind, and that is that many people will be prescribed one of the medications for dementia at their diagnosis. They may hear the words galantamine or donepezil or rivastigmine. These are the common cholinesterase inhibitors, and they're prescribed usually in the mild or the middle stage of the disease. But it's also important to know that there are the other drug that was alluded to, the NMDA antagonist, is often added at a later stage in the disease. So although we think of this in terms of I've started this, should I carry on? Some may have the memantine, the NMDA antagonist, added to their treatment at a later stage to try to bring about further stability and slowing down at a late point in their illness.
Thank you so much, Stuart. I think that was really, really insightful. We have had a question already, and I think it links on to some of your last points. So I'm going to ask this one slightly earlier than I might do, although we're really at the point now where I'm very welcoming of people asking questions as well. But somebody's asked a question about the antipsychotic medication, and you mentioned antipsychotic medication when you were talking there, Stuart, which is what made me think actually perhaps there's something that we can talk a little bit there about these kinds of drugs and how they might be used. And we do know that they can be used in terms of helping to manage hallucinations. And you also spoke a little bit about antidepressants. So I wondered if you could, because a question I get asked a lot again is, should we use antipsychotics? Should we not use antipsychotics? Antidepressants, beneficial, not beneficial, that whole depression, dementia debate initially. So I think it probably warrants a little further conversation at this point. So should somebody take an antipsychotic? What should we be saying around that, do you think?
Oh, that's like a loaded question. So I guess a little bit of background as to antipsychotics is useful at this stage. So antipsychotics are a group of drugs, as you've mentioned, that are commonly used for hallucinations and delusions, and what many people would consider to be associated with things like schizophrenia. So these have a long history dating back to the 50s of being medications that would work on those very active symptoms of those types of illnesses. Over time, they became commonly or more commonly used in dementia. And through some amazing research and determined efforts, it then became common practice, if you like, for us to look at those with dementia who were still taking antipsychotics and to ensure that they were reviewed. The evidence started to show that if a person with dementia was taking an antipsychotic for an extended period of time, their risk of cardiac events, strokes and heart attacks, were significantly higher than in other populations. So it became very important that we start thinking, if someone with dementia has been prescribed an antipsychotic and is still taking it, do they still need this Is there another way? What are our options? Now that makes it sound as though we just take everybody in that group off of the antipsychotics, but obviously it's not that symptoms. There are some antipsychotics actually have a license for agitation in dementia, so they have been evidenced to provide some benefit to very specific symptoms. But to be clear, for most people with dementia, we're not necessarily using them for the psychotic elements. They're more likely to be used for symptoms of upset and extreme agitation, where it's a last resort and there's a risk to the patient or to others around them. I think the bottom line with these is they should be reviewed regularly, they should be reduced, and they should be discontinued wherever it's safe to do so. Now that decision should be a big multidisciplinary decision, and should involve families and care staff if someone is in a care home, and GP and any specialists who are still involved. I think it's also something which is being picked up far more proactively now that areas are looking at structured medication reviews of patients in care homes, that this will be something that's prioritized a little bit more. I think in terms of where these symptoms are occurring, it's also important that we don't just think the antipsychotic is the only approach to managing a person with dementia's extreme other non-pharmaceutical interventions. Have we looked at the immediate environment? Have we looked at issues around that environment which may be causing or leading to distress? Have we looked at whether the person's actually experiencing pain at the moment? Have we looked at their sleep pattern, issues to do with continence, structured activity throughout the day? So again, it's not a one size fits all, but I think the most important response in terms of antipsychotics in dementia is they should not be long term unless it's absolutely clinically necessary, and even when they are, they should be regularly reviewed, and all other methods of trying to mitigate those risks and resolve those symptoms should be looked at. So I mean, that would be my take on antipsychotics, I guess. You mentioned antidepressants.
Yeah, that's right. Because we know again that many people may experience depression as
Mm,
well as dementia,
yeah.
and I know that for lots of people, we still hold on to this kind of concern about antidepressants, and people thinking, oh, they're going to get
Mm.
addicted to them, they're not going to manage to stop taking them once they start them, and again, it's one of those conversations that rumbles, and if you had a penny for a pound, you'd be a rich man, wouldn't you? And I guess what advice would you give around that if someone was concerned about whether they should take an antidepressant or not?
So I guess again, in terms of the domain we're looking at, which those with a diagnosis of dementia, the some of the evidence would suggest that antidepressants are not as effective for those with dementia, particularly in an earlier stage, as we might hope. But that doesn't mean that they don't have a benefit for many. I think antidepressants may often be prescribed when someone has had a diagnosis and is still adjusting to that diagnosis and the implications of that. Equally, there are those at a much later stage of dementia who would benefit from an antidepressant, but we may not necessarily be identifying the symptoms they have as being depressive symptoms. We may be putting them down to something else. We may be calling it agitation or irritability, and actually not thinking of that in terms of, is that a depressive symptom, which we should try to address. Now, you're right. People will often say, are these addictive or are they harmful? Am I going to get hooked on these? And the answer to that is, if you look at what addiction means, then no, they're not addictive. Not in any conventional sense of getting cravings, and those sort of symptoms of needing that drug to sustain a current level. So in a conventional sense of what addictive means, they're certainly not addictive. But a small caveat to that is that if you stop taking them very quickly, if you suddenly withdraw, you will get withdrawal symptoms. And that's an important distinction, because what's happening with the common antidepressants, the SSRIs, is your brain is the cells are adapting to adjustments in the receptors that these antidepressants have brought about. And if you pull that away too quickly, the receptors go into a bit of a panic mode, and you may get nausea and tremors, a sort of type of feeling of withdrawal. So they're not addictive, no, but you need to discontinue them if that's your plan under medical advice. They're not. Most would agree they're not harmful, certainly not in the age groups that we're discussing here. I mean, they have had a bit of a bad press over recent years, but much of the concerns that have been looked at in the past have been in very young populations, sort of, not really sort of adult stage. So in terms of adults and older adults, these are generally not considered to be harmful. But overdose with any medication is a concern. And if you happen to be on an older antidepressant, what they used to call tricyclics, amitriptyline, imipramine, these sorts of drugs, overdose is much, much riskier in those drugs than it is in the newer SSRIs. And for that reason, the older drugs are not used quite so much. The sense of harm, I guess it's also important that there are cautions with any of these, because as we've talked about in terms of polypharmacy, an older person might already be taking other drugs that could interact or increase your risk. So if you were taking what they loosely term an NSAID, an anti-inflammatory, that's already carrying some risk of being irritant to your gut. If you start an SSRI as well, you're adding to that load. So there's always cautions around the conversations as to whether to start these or not. And to consider whether there are any likely interactions, and that's part of that conversation around consent as well. As I've said, I think risks are largely age specific, but one thing that is worth underlining, because people will look for alternative treatments, is to avoid things like St John's wort if you're already taking an antidepressant. The evidence for things like St John's wort is perhaps still a little 50-50, but what you wouldn't want to do is be taking that alongside an antidepressant, because that would be potentially harmful. I think I would also probably underline, in terms of antidepressants, that most of the evidence is around them being much more beneficial in moderate and severe depression. Although they can have benefit in mild depression, it tends to be that they're much more beneficial where the depression is more marked. And where someone is experiencing a mild depression, are there any non-pharmacological options that we can consider as well? Mindfulness, peer support, amazing things like social prescribing that we can access. These are all alternatives as well. So I guess sort of short question, long answer. Addictive, no. Harmful, most things can be. But have a considered decision around taking them, discuss the risks, have them regularly reviewed, and don't stop them suddenly.
Perfect. Thank you so much. And it's, as always, these spaces go so quick. I'm always amazed when I look up and see what time it is, and we're whizzing through this hour. So I do want to open up the mic so that people can ask questions live if they want to. They can come up and ask us a question. We do have a couple that are submitted already. In fact, we've got quite a few that have been submitted. So I'm going to do my best to try and go through some of the ones we've already asked and the ones that have been asked already in the space. So we've kind of talked about hallucinations a little bit already, and actually how you might deal with somebody who's hallucinating. But we've had another question that's been asked, which is around, this was asked by a direct message, which actually, what should you do if somebody misses their medication? And I don't mind who answers that one, actually. Is it more of you one, Hannah, to hear your voice again for a little bit, perhaps? What would you advise if someone's missed some of the medication? What should they do?
Yeah, no, I'm happy to answer that one. The general advice is that if a person misses their medication, an individual dose, they should take it as soon as they remember, as long as it's not too close to their next dose, in which case they can just skip that dose altogether. It's because these drugs, they work by accumulation generally. So an odd missed dose here and there is not going to have a massive detrimental impact to that person's treatment. But if it's kind of becoming a regular problem and there's several days of back-to-back missed doses, they'll need to kind of have a discussion with their GP or prescriber about, they might need to start at a lower dose again and kind of work that out. But yeah, an odd one missed here or there, just take it as soon as they remember.
Perfect, thank you. And can I ask you another one actually as well, because I think
Sure.
it links. So somebody's asked a question as well, and actually what they've said is, Mum has got a cupboard full of medication. What should I do with this medication? And I guess this is around how to prevent that polypharmacy, perhaps, or just, in fact, we know people take lots of drugs, they get lots of drugs, and they potentially might sort of store them for a while. So what advice would you give in that case?
Yeah, so this is kind of a common thing that we will see in community pharmacy. Like, we'll encounter this quite a lot. So I think the first and foremost thing is it's important to establish which of these medications that mum is actively taking, and if there's any medications that are there stored in the cupboard that aren't part of her medicines plan anymore. So what I would do is I would recommend taking the medications into the community pharmacy, of course, obtaining consent first. And the team will kind of have a look at the medication history of the patient and see which ones are still required for treatment. They'll also have a look through the treatment, the drugs that are brought in, and see if there's any that are expired. And we safely dispose and destroy these on site as well. And it's, if you do have expired medication, please bring it in and don't try to destroy it yourself. And to avoid this kind of accumulation happening in the cupboard in the future, you may want to arrange delivery services with a pharmacy provider. So what they can do is arrange weekly services of delivering this drug so that they're not accumulating in the cupboard. And this can just minimize the risk of overdose too, because if your cupboards are getting full of drugs, it's likely that, an overdose is more likely to occur. But if a person prefers to go out and get the medication themselves, you can also arrange weekly pickup. So the pharmacy will just dispense the medication for that week, and it just stops this accumulation occurring too.
Thank you so much, Hannah. And another question for you as well, and then I've got one for you, Stuart. But in terms of how somebody's medication, how often should that be reviewed? What would you kind of recommend as being a good, frequency for that to be reviewed?
I think it really depends on, number one, what medication they're taking, how many they're taking, and how stable they are on that medication. So generally, medication reviews might only really be required annually, so once a year. But if someone is on a dementia medication where it's being titrated, they might need more regular reviews. And these reviews, they can happen across different care settings. So they can happen with your GP in a medication review, but you can also have a medicine review with your pharmacist, and that's called a medicine use review. So they're slightly different, but there's different settings. And also, if someone is starting a new medication, so something new is being added to their plan, this will also need reviewing. And again, this will happen with your community pharmacist during a new medicine service review. So there's different types of reviews. They can happen at different times and at different frequencies. But if at any point someone feels like they might benefit from a medicine review, they're feeling a little bit unsure, they've lost their way with their medicines and with their medicine plan, they should just try to arrange one with their healthcare worker, whoever they're feeling most comfortable to talk to. So whether it's their GP or the practice nurse or their pharmacist, just get in contact and get that sorted.
Perfect. Thank you so much, Hannah. So, Stuart, I've got questions are flying in. So I've got a question for you, Stuart, and I've just put a question from Tracy O'Brien in the nest at the top. So, Hannah, if you could have a look at that, and we'll come back to you in a minute. So, Stuart, I think this one's possibly better with you. If somebody thinks that their parent should take an antidepressant, but actually the parent isn't sure about doing that, there's something they're not sure about, how to raise with them, what to do, and how to raise this with GP as well. So someone saying about dad's GP and getting it prescribed. What should they do in that situation?
So I guess again this comes back to the sense of what the benefits are going to be, whether other interventions may be as beneficial. So as we've said, that antidepressants for many can be beneficial, but some of the evidence for their use in dementia is still quite widely debated. So if someone is feeling that their parent needs an antidepressant, but you're struggling to persuade them, I guess the first port of call really is, why is that person resistive? Why does the person not feel that they need this antidepressant the way that you believe they do? Do they have any sort of previous experience with antidepressants or medications, or beliefs around what these tablets might do? We talked earlier about are they addictive? Are they harmful? And of course. The media has a role to play, and sometimes we can read something and then form a belief based around that of what something will do, or it not being as beneficial as it actually is. So I think to actually try to explore why somebody has views that they don't want to start that medication, they don't want to see their GP. Do they believe it's a dependence form, or do they believe it's harmful? That sort of thing. I think it's important to try to convince a patient to see the GP themselves, to actually go and have that conversation. And I think also to consider whether there are any non-medication interventions that the person might agree to in seeing their GP. So although the appointment with the doctor may not necessarily lead to a prescription for an antidepressant, what it might lead to is an agreement, if the person's still at quite an early stage in their illness, that they'll perhaps be referred to someone like a social prescriber, someone who can sort of support with other areas of their life. So it may or not necessarily be whether or not the medication needs to be prescribed. It may be explore that person's views, and ultimately I think also, does the carer have consent to discuss the patient with the GP and have those more frank conversations about why you're worried, what symptoms that you're actually seeing, and whether there are other things that need to be explored before going down the route of prescribing an antidepressant.
Perfect. Thank you so much, Stuart. So, Hannah, we're going to stay with antidepressants for a little while, actually, and I'm assuming you've by now had a chance to read the question from Tracy and have a little think. I think this is probably one that you're best placed to answer, if you're okay to take that.
Yeah, so just to say that the question asks if fluoxetine, it says, can I ask, is fluoxetine a common or effective antidepressant for someone with FTD, which is frontotemporal dementia, semantic language variant? I have to admit, the semantic language variant is not something that I'm fully familiar with, but I know that antidepressants, particularly SSRIs, for which fluoxetine is one, are common treatments for people with frontotemporal dementia. And we kind of highlighted before that the treatments that we mainly discussed in today's transmission were related to kind of Alzheimer's disease, and there's different treatments for different types of dementias, and antidepressants like fluoxetine are actually first line for people with FTD. So yeah, they are common, and they're shown by multiple studies to be really useful, and they're primarily involved in kind of controlling or managing the behavioral side effects that are associated more heavily with FTD than they are with other types of dementia. So yeah, they are.
Perfect. Thank you very much. We've also been asked a question, which is from Jude Ducombe, which I've popped up in there as well, which is about PSP, which is progressive supranuclear palsy. Sorry if I pronounced that correctly. Get my teeth in, and whether that's is something that can be medicated at all. Now, I have to admit, I've not come across anybody with using medication for this, so I'm not sure whether you have, Hannah, or you have, Stuart.
Yeah, it's not an area that I'm completely familiar with at all either. Stuart, do you know?
No, I mean, PSP forms one of the dementias which would generally be considered to be amongst the rarer forms, and perhaps more common in those under 65. But it's not one in which medications have been either demonstrated or particularly researched to provide any benefits at present. And I think part of the the difficulty of it is the pathway that's formed over many years is the conventional treatments for dementia are for the majority of those with dementia, therefore Alzheimer's disease, and some of that has evolved into things like mixed dementia and so forth. But the rarer forms of dementia, there's just not the evidence base that conventional dementia treatments would work. Now, whether antidepressants would work, I think that would be more dependent on whether the person is demonstrating symptoms that correlate with depression, and whether that would be seen as a worthwhile trial. But as a general answer, then no, I don't know of any specific evidence for that.
And I guess I was just thinking myself about it. It would probably depend a little bit on actually what type or particular type of PCP somebody has, and actually whether something might help them. It would depend on actually what it is they they might slowness or stiffness or balance or eye movements, and there might be certain things that could help with that. And I was having Botox injections to potentially help, but it will depend very much on the type. I hope that helped to answer your question a little bit there. We've had another question as well, which is actually a very practical question, but it's around storing medication. So can I ask you to just quickly cover that one for us, Hannah? And just to let people know, we're really coming into the last 5 minutes here. So if you do have a question you want to get across this evening, but how should somebody store medication? You talked a little bit about it earlier, actually, when we answered the question about that cupboard full of medication. what
Yeah.
advice would you give?
I think yes, the general advice is that this is a bit like it is an important consideration, and it's an important question, especially if there are children in the home. So keeping medication locked away in a drawer or in safety boxes out of sight and out of harm is probably the best advice. So keeping medication out of sight, but otherwise, generally with these medications, like all medications, they just need to be stored in a cool and dry place. So like a kitchen cabinet or somewhere out of reach.
Sorry about that. You caught me reading questions when you finished there, Hannah. Sorry. I'd gone off to try and check there was no more questions that had come in. So there is another one that's come through somewhere else, which is around about how do you ensure that somebody takes their medication as prescribed? And I know this is really tricky. I know this is a really hard question, and it's one we get asked quite a lot, actually, is how do you encourage somebody to take their medication if perhaps they're not wanting to do that? And I don't know whether, I guess maybe it's more of a you one, Stuart, or one of you, Hannah, or one you both want to have a go in 3 minutes. Just
I'll,
how
I'll, I'll,
go on,
I'll jump
Stuart.
in and give it a try.
Go for it.
Okay, but this is a big can of worms for 3 minutes. So look at the specific medications and any risks associated with that. I mean, we've talked a lot about treatments for dementia, but there are actually far riskier medications out there that somebody might be refusing to take or taking too many of or omitting doses. There are drugs which have very narrow windows of when they're beneficial, things like warfarin and lithium and digoxin. So, for one thing, start with what are we actually looking at here? Is it something risky or safe? Have that conversation with your GP and your prescriber. Often it may be that it's just to do with the timing, the time of day. It may be that changes to when somebody takes their medication may actually be all that's needed here. Taking things 4 times a day is onerous for anybody. So, can these be rationalized? Can they be given at a different time of day? Is it perhaps more likely that the person will take medication in the morning than it is in the evening? For some with dementia, the evenings can be far more challenging with symptoms such as sundowning, when maybe less likely to see things the way they would earlier in the day. So look at changing the timing. Look at actually, are all the medications still necessary and required? I don't think areas like covert administration of medication are something that we can necessarily get into at this point, because that's a whole other area. But I think there's that balance between, does the person actually really need it, and what are the harms of not taking it? Donepezil, for instance, we've talked about drugs for dementia, but if the person really doesn't want to take that anymore, what is the implication of that? It's not life-saving, it's not life-sustaining. We should at least honour that person's wishes as much as we possibly can. But that's probably a poor 3-minute answer to a complicated area.
I know it's always happens in these spaces. They go so quick, and I think you gave us a really good answer there. And I guess for me, I was just thinking about other things that we can do to try and encourage someone to take their medication as prescribed. And we know that there's all sorts of bits of tech and kit out there. There's alarms when take their tablets to give them that reminder, and I guess if you suspect that somebody isn't taking their medication as prescribed, it's important to discuss that with the person prescribing and say, look, mum's been prescribed this, but actually she's not taking this, because there might be some indications to that you're not aware of, and that the person prescribing thinks that they're taking and they're not. So I think that is important to have that dialogue. Hannah, anything? And we are right at the end. I can see your thumbs up, so I'm guessing you're okay with that answer.
Yeah, no, that's exactly it. Like you said, there's loads of bits of tech, and there's even more simple things, just like charts and stuff like that on the wall, like whiteboard charts, just to encourage that person to make it part of their routine. So non-compliance is an issue amongst everyone, not just people with cognitive impairment. So, and like we said before, we discussed kind of pick up and delivery services. So these can also help to establish a routine in terms of medication taking. But in community pharmacy, we also have the monitored dosage system, so like the pre-dispense trays. Again, probably too short to talk about this right now, but they can be a good aid as well for someone.
Perfect. Thank you so much. We're right at the end of our session this evening, and I always believe they should start and end on time. So I want to thank you both for what's been a super interesting session this evening. Really, really informative, knowledgeable space, and certainly I've really enjoyed the conversation. So thank you both. Hannah has also helped us to produce a leaflet, an information leaflet that we've shared at Dementia UK. So just want to point people towards that. That's on our website. So if you go to the Dementia UK website, there's a brand new shiny leaflet on there for you to have a look at, and you can download it and order copies, or just have a look at it online. So just to draw your attention that way. And thank you massively, Hannah, for your help that way in producing that as well. The other thing to tell you is that we've got a brand new Twitter space coming to you on the 1st of December. So that's in the nest, which is the little bar at the top. You'll be able to see that. So do click on that and set yourself a reminder so you can come on the 1st and join us. I'm going to be joined by a chap called Manny Kang, who some of you may know of. He's one of a fantastic fundraiser, and I'm delighted that he's coming along to tell us all about his work and what he's done in the past to raise funds and awareness around dementia. So that's it from me. Thank you so much, Hannah. Thank you so much, Stuart. I'll let you come and unmute, say goodbye to everybody, and then we will close the space. But thank you, everybody who stayed and listened to us this evening. Thank you so much.
Thanks, everyone, for your engagement.
Thank you, Hannah.
Thank you. Thanks a lot.
Thank you, and take care. Enjoy the rest of your evening, everybody. And as I say, if you're listening again, I hope you enjoy listening to the space that way too. Thank you. Bye.